And then if you have any suggestions at all, please give us some feedback, or you can email us. So, all things trauma. So just comment in the chat different types of trauma and different sort of considerations of trauma. Are there any special cases that we need to be aware of? Are there any special populations that we need to be aware of? Does anyone have, how do we get the link, please? It'll be at the end. It'll just be at the end. So post HJ. So just a question of different types of trauma, different populations with special or different considerations. So RTA, pediatrics, yeah. So an RTA is a road traffic accident. What we like to say is a road traffic accident. Pediatrics is really important as well. Yes, so chest, abdominal trauma, pelvic trauma is really important. Anything else? Head trauma, absolutely. Yep, fire, burns. So different types of burns, obstetric trauma, elderly populations are also really important to be aware of as well. Fantastic. Yeah, so you guys get the idea. So different types of trauma, so pelvic and long bone fractures, thoracic and abdominal injuries, burns that discussed, obstetric trauma, spinal column injuries, so spinal injury is really important, head injury or brain injury, and different types of trauma, including blunt trauma versus penetrating trauma, and we'll go through what that means in a little minute, okay? So trauma in medicine. So trauma basically means any injury that causes harm, but I think what we mean by trauma in medicine is, or in trauma in this context, is major trauma, and that is quite a serious series of events. It's multiple serious injuries that could result in permanent or semi-permanent disability or ultimately death. And these can include multiple different mechanisms, such as a blunt force versus a penetrating force, gunshot wounds, stab wounds. We've already discussed road traffic collisions. And major trauma in the UK is defined with an injury severity score, an ISS, and essentially it looks at 6 different types of body system or different types of injury, and that gives each section has a sort of mild, moderate, severe, or unsurvivable level of severity, and that basically corresponds to a number. And an injury severity score over 15 is defined as a major trauma. So a patient who scores over 15 is defined as major trauma, and an ISS of 9 to 15 is moderate trauma. So that's what we would, that's how it's differentiated. Some really interesting facts. Basically, trauma accounts for about 18% of the world's total diseases. It's thought that 9 people die every minute from a major trauma. And road traffic accidents, or RTAs, RTCs, they contribute to over 1 million deaths annually and 50 million significant injuries annually. And the National Audit Office suggests that approximately around 5,000 people a year in England alone result in death due to major trauma. So it's quite a big thing, to be honest, and the fact that recognizing it and managing it ultimately will ultimately improve patient survival and ultimately patient care. So I thought that was quite an interesting fact, a couple of facts. Trauma is thought about in 3 peaks, basically. So there's 3 different types of distribution. It's called the Trimodal Distribution. I'm not sure if anyone's heard of this, but essentially you've got 3 population groups. The first peak, or the first peak of the trimodal distribution are those who don't survive the initial trauma. So those who may die in a high-speed road traffic collision, and that could be as a result of quite a large traumatic brain injury or a major bleed in the thoracic or abdominal cavity. The second peak is, are you talking, sorry guys, are you talking to me, mic off? Please mute those talking. Apologies. No problem. Apologies. This is what happens whenever one person is fielding the questions and doing the talk. So if, yeah, sorry to interrupt myself there. The second peak, going back to it, patients will pass away usually from minutes to hours, and that's with, for example, with large long bone or pelvic fractures resulting in big bleeds, or solid organ lacerations resulting in major hemorrhage. And then those who pass away in the third peak is usually, whilst the patient has been initially resuscitated, they may die from something like sepsis or multi-organ failure in the weeks after their initial trauma. Okay. So the different types of injury, I think this is really important to have a good appreciation of. I find it quite difficult to get my head around this, but blunt versus penetrating. So blunt force injury is essentially like an RTC. So something a patient may or may not collide at quite a high speed and have a blunt force trauma anteriorly, posteriorly, and depending on the mechanism, that may give you some clues as to what type of injury you would expect. So, for example, if a patient was in a car going quite quickly, or a vehicle going quite quickly, and it was a frontal impact road traffic collision, not infrequently, a posterior dislocation of a hip, it requires quite a lot of force, that might happen. So that is seen in a frontal impact RTC, whilst a rear impact RTC may have a coup or contra coup injury. And that is an injury where you get essentially a whiplash injury, where the brain, it essentially jiggles or moves forward quite quickly in the skull cavity and whips back very quickly. So you get an anterior bruising and then a posterior sort of blushing or hemorrhage. So that's quite a typical injury of a rear impact RTC. And then the classic fall from height. So if the patient falls from height onto their feet, the classic sort of presentation or medical school presentation, bilateral calcaneal fractures and bilateral foot fractures, essentially. And penetrating injuries, so you think about stab wounds, you think about sort of long weapon or blade wounds. You can get pathology such as cardiac tamponade if say a blade pierces the pericardium. You can get an overflow and backflow of pressure causing a tamponade. You can get pneumothoraces. You can get simple pneumothoraces, large pneumothoraces, or hemothoraces as well. So it's quite useful to have an appreciation of that. And then what we've discussed a little bit, so thermal injuries, so burn injuries can be categorized into thermal, electrical, and inhalation injuries. So a thermal injury is like just like a hand in a fire type injury, so you can get different thickness types of burns. Electrical injuries can result in cardiac arrhythmias and can cause muscle necrosis and ultimately compartment syndrome, so increase in pressure in the compartments of, say, your lower limbs. Compartment syndrome can also happen in the upper limbs as well. And inhalation injuries can be caused by smoke, it can be caused by toxic gases, and you can get injuries such as upper airway swelling or ultimately pulmonary edema and breakdown of the alveolar interstitium, causing edema. So all of these things need to be recognized because each has their own sort of way of dealing with it. I thought this was quite useful. Prevention is ultimately the best step. So it's a sequence of events in a patient who undergoes trauma, essentially. And as we've mentioned, there are lots of injuries and lots of deaths caused by trauma. So prevention, there's quite a lot of money and quality improvement that goes into prevention in the UK. Then ultimately the patient will get pre-hospital care, so initial identification of life-threatening injuries and resuscitation before transfer to an appropriate centre, such as a hospital. Then when the patient arrives, they usually get the acute trauma care, and this starts from the initial assessment, basically as soon as they get through the door, and the real stabilization of their physiology and their injuries at the time. That's when everything occurs really in A&E and at the front door. Afterwards, then they get their ongoing care, sort of urgent but not critical surgical interventions, and ultimately the end goal is to get the patient discharged. And whether or not the patient needs different levels of rehabilitation, for example, a level 3 rehab is level 3 rehabilitation is non-specialist led rehabilitation services. So the majority of the population will receive level 3 rehab, whilst a level 1 rehabilitation, patients that have high spinal injuries, for example, and paraplegia, they have complex rehabilitation needs. There are certain centres in the UK that have bespoke rehabilitation pathways and teams that deal with these types of complex people and patients. And they essentially are led by rehab consultants, so rehabilitation medical consultants, because it is a specialty in its own right, so it's quite useful to have an appreciation of that. Just going back, because Dr. Addy's asked me a couple of questions. With dirty wounds and the absence of past medical history, when should a tetanus injection be administered? So in a patient who comes in with a dirty wound, or if you're concerned about rust, a tetanus injection would be indicated if they either can't remember if they've had their booster, they haven't had their tetanus injection, or you're uncertain, because I think it's better to treat rather than to live with the repercussions. I'm pretty sure that those are the 3 indications, but if anyone wants to correct me, I'd be very happy to learn from them as well. As well as that, just for those who haven't been into hospital yet and haven't had their clinical placements, there are several different types of hospitals. So district general hospital is one with sort of non-tertiary level specialty services. So although A&E has a minors, a majors, and a resuscitation area, trauma can still come into a district general hospital, but typically a patient will be stabilized, resuscitated in resus in a district general, and they will ultimately be transferred to a major trauma center when it is safe to do so, for definitive treatment. And definitive treatment can mean a whole host of things. So a patient has a pelvic fracture, for example, they will need orthopedic input. If they've got a major bleed, they may need general surgical input, or if they have a spinal injury, they may need neurosurgical input or spinal orthopedic input. So ultimately, I think it's important to appreciate that patients can be resuscitated and treated in district general hospitals, but ultimately they will have to be transferred to a major trauma center in most cases. So sequence of events. Anyone got any questions whilst we've got a natural break in the talk? Just so I can field some questions. I can try. I'll give it another 10 seconds. No, okay, let's go on then. So we've already touched on this a little bit. So in the pre-hospital phase, the patient will be, I'm really sorry guys, I've got a question here from Ahmed. So what is the difference between A&E and trauma departments? So A&E, most hospitals, most acute hospitals have an accident and emergency. And they are essentially departments that look after a whole host of different patients. They deal with minor injuries, acute medical patients, acute surgical issues, such as appendicitis, acute oncological issues, cancer issues, for example. But all A&Es will have a resus department where essentially the most critically unwell or those who come in with trauma or major trauma, they will be stabilized and made safe to transfer in the resuscitation area of the A&E department. In a bespoke major trauma center, they will have typically they will have a major trauma team, and we'll discuss that in a little minute. But a major trauma team will be typically an A&E consultant who is the trauma lead, and they will be fielding different patients that come in with lots of different types of trauma. We'll talk about the trauma team in just 1 minute. Let's go through the pre-hospital phase. So the pre-hospital phase, essentially, I have not done much pre-hospital, but I've spoken to lots of pre-hospital doctors and those who work in and around sports events and big big sports events. And essentially, if anyone has a major trauma in a pre-hospital environment, the primary concern is identifying life-threatening issues, stabilizing the patient, and getting them to hospital as soon as possible. If they're concerned about a C-spine injury, a high neck injury, immobilization is a huge thing. We don't want to worsen the injury because that can cause a lot of badness for the patient down the line. And the decision to transfer to definitive care or trauma center, lots of different factors, but these include sort of the mechanism of injury, the events of the injury, if the patient is stable with their observations, and the treatment that they've already received in the field as well. So usually, hopefully everyone has heard of SBAR or a pre-alert or an ATMIS. So for those in the first year of medical school, SBAR is really a useful tool. So it stands for situation, background, assessments, and recommendations. So that's essentially, you can describe any patient case with an SBAR. A pre-alert is those, for example, where paramedics will call through someone that they've seen in the field, and they will call to an accident and emergency department, and they will pre-alert the department that they've got a patient that is coming in with, for example, a major trauma. ATMIS is another tool that is used quite regularly. It stands for age of patient, the time of the injury, the mechanism of the injury, the suspected injuries, the signs and the symptoms, and that's broken down into each patient, each organ system, and then the treatment given. So just a little question for everyone. 24-year-old male in a high-speed road traffic collision with prolonged extrication. The patient is normally fit and well. What type of injuries would you be expecting in a high-speed RTC, let's say 60 miles per hour with head-to-head collision with another car? What would you be expecting, or what potential injuries may this patient have? So blunt force trauma, absolutely. hip dislocation, what we've discussed, absolutely, that's potential. Anything else? It's really useful to think about this like from top to toe. So yeah, coup, contra coup, possible head injury, absolutely. Pelvic injury. Neck injury, yeah. So C-spine injury, cervical spine injury, really important. Chest penetration. Yeah, this is a really sort of high risk mechanism of injury. You could have multiple traumatic issues going on. Apologies, I'm just admitting someone else here. Yeah, fine. Okay. So on assessment, so we've done the situation, the background, the assessment. So the patient is immobilized in collar and blocks because we're concerned about a spinal injury or a C-spine injury. They're maintaining their own airway, so they're breathing for themselves. And we've noted that he's got a forehead bruise on the left side. He is alert to voice, or if you want to do a formal Glasgow coma scale, his eyes are 3, so he is opening his eyes to voice. He's slightly muddled, so his voice is 4, and he's localizing to pain, so M is 5. So his formal GCS is 12. He has a clear chest, but he is tachycardic, so his heart rate is quite high, and is hemodynamically stable, so his heart rate is slightly high at 110, but his blood pressure is completely normal. Fine. So I think with that mechanism, we're really concerned about head injury and C-spine injury because we've immobilized the collar with his neck with a collar and blocks, and we've seen a frontal hematoma. The paramedics very kindly inserted 2 large bore cannula, and the estimated time of arrival is approximately 12 minutes to ED. So that encompasses our SBAR, our pre-alert, and it touches on our at-mist as well. Okay, so that's just a good example. Just trying to admit someone here, apologies. Okay. So this is the hospital phase. This is if you're doing medicine, if you're doing physician associate studies, this is where you will likely see major trauma or trauma patient in resus. So this is it kind of looks like a bit like a spaceship. This is where acutely, critically unwell patients are admitted through the A&E doors, through the emergency department doors, and they are stabilized and life-threatening injuries are addressed, and the patient is sort of initial treatment is started and the patient is stabilized before going on to definitive care. On the right-hand side, this is what would be a typical trauma team. So usually there's an airway specialist, like an anesthetist or a senior A&E doctor at the airway, and then they usually have their airway assistant, such as an ODP or someone who's trained, like a senior nurse. And then usually the doctor will assess from A to E, whilst the nurses attach monitoring, and they may or may not, depending on their skills mix, they get access, whilst another doctor may or may not do procedures if they are indicated. I think it's really important to look at where the team leader is standing. I'm a really proactive person, and if I'm ever leading a team, I will always try and get involved in assessing or managing the patient or doing a procedure. It actually takes quite a lot of temperament and skill to stand at the end of the bed and have an oversight as to what everyone is doing. Team leader is extremely, extremely important because they have essentially overall responsibility of the patient. The scribe, that's usually done by a trained HCA or a nurse. Again, really important to document timings of administration of drugs when the patient arrives in the hospital, drop in GCS, all of these different things. And then depending on the type of injury or trauma, you get other allied healthcare professionals like radiographers. They can do chest x-rays. You've got different teams such as surgeons, the general surgeons, orthopedic surgeons. If it's a pediatric trauma, you might get a pediatric doctor. If it's an obstetric trauma, you might get an obstetrician. Lots of different people. And resus can get, if you've ever seen a trauma call, or a pediatric trauma call, in fact, that resus can get extremely crowded and quite busy. But each person has a defined role, and communication is really key. Great. So I think we'll go through the primary survey. It's essentially like your A2E assessment, and hopefully everyone, whatever level you are, is familiar with an airway, breathing, circulation, disability and exposure assessment. I've just got another question here. Apologies. So how does blood loss impact on heart rate and tachycardia in an athletic young guy who has sinus bradycardia? We will talk about this in a little while, Dr. Addy, if that's okay. I'm not going to go into it too much detail, but we're going to go through the different classifications of shock in a little while, and we'll go through a standardized way of remembering it. Okay. So trick is keep it really simple. I think one of the main differences is with airway comes restriction of C-spine. If you can remember one thing today, airway is extremely important, but C-spine comes with it. So if you suspect, if somebody comes in with a high-speed road traffic collision mechanism, the chance of a C-spine injury or high spinal injury is really high. So making sure that you're immobilizing and restricting the movement of the C-spine is extremely important, because you don't want to transect the spinal cord. That will leave the patient paralyzed, and it can kill the patient as well. So restriction of C-spine is extremely important. Breathing. So I've just been asked by Nadu, please, doctor, from your previous slide, what's the position and the role of an F1? I'll just go back very quickly. So F1s are really important, especially if they're in A&E. I'll go back, apologies. So F1s typically, in my experience, depends on trust to trust, but F1s in A&E are usually supernumerary. And depending on your level of 1, confidence, 2, competence, and how much the seniors trust you, your role can really vary. So in simulations as an F1, I got access. I was a team leader in some simulations. I did an A2E assessment. I was also a scribe as well. Essentially, you're going to, if the more exposure you get to this, the more confidence you're going to have. And watching a major trauma in action, you gain a lot from that, from sort of the more senior doctors. Just the way people communicate, closed loop communication, really clear and distinct roles, and everyone's kind of working on the same team, and it's quite interesting. So definitely recommend, if you get the chance, to watch a trauma call in your hospital if you can, if the opportunity arises. Okay, so going on to breathing and ventilation, circulation with hemorrhage control, then disability and neurological status, and exposure and everything else, and then additionally environmental control. So similar to the A&E assessment, I think let's start with airway. Really important. Without an airway, the patient will not live. Bottom line. So best thing to do is you look at the airway. Does it look swollen? Does it look obstructed? Can you hear? Is the airway nice and clear? Are they gurgling? Are they snoring? Are they making strange noises and they're a bit sleepy? And then finally, look inside. Is it clear? Is it obstructed? Is there a foreign body? Is there a fracture? Usually, there will be an airway specific doctor and sort of a bespoke personnel or an airway trained doctor on the airway. But it's important to recognise how you assess an airway. To open the airway and C-spine injury, would you just use the jaw thrust technique? Absolutely. So really good question. You need to mobilize the C-spine. So that was a really good question. So typically there are several different ways to open the airway, different maneuvers. One is head tilt chin lift, which maybe you guys have heard of. You wouldn't do that in a trauma patient if you suspect a C-spine injury. Jaw thrust is just as effective. And if a patient is coming in with, a suspected C-spine injury, likely they will have a head injury as well, and their GCS might be quite low. So they will more often than not tolerate a jaw thrust. Again, people with experience will be able to immobilize, assess airway with immobilization of C-spine, that's meant to read. Will immobilize the C-spine whilst getting an airway in situ. And then the question is, if the patient is not maintaining their own airway, to administer high flow oxygen. So all trauma patients will get high flow oxygen, and that's 15 liters of 100% oxygen through a non-rebreathed mask, so a mask with a reservoir, and to get as much oxygen into the patient as possible so they can perfuse their organs as best as they can in that scenario. And the question is, does the patient need a definitive airway? And a definitive airway is defined as an airway that is below the level of the vocal cords. It is a closed system, and there is a cuff below the vocal cords. And usually that's done by intubation. So that's the question that the airway doctors will, and the team lead will be asking. Lots of different airway options. Hopefully some of you recognize this. So a definitive airway really is the only definitive airway here, or one of the definitive airways is intubation. So as you can see, the tube goes below the vocal cords, a cuff of it is inflated, and it is essentially a closed system. You've got different adjuncts, including an oropharyngeal airway in the top left. They are also called Goodell airways, and they can be sized from the angle of the mandible to the incisors. And it's depending on your patient. If it's a pediatric patient, they'll need a smaller Goodell or oropharyngeal in comparison to grown adults. An LMA in the top right is it's not considered a definitive airway because it sits above the vocal cords. However, if a patient has an extremely difficult airway, or you need a bit of time to, if the anaesthetist needs a bit more time for a senior doctor to attend to help with getting a definitive airway, this is an appropriate alternative in that instance. An NP, or an nasopharyngeal airway, that is a long tube that goes in either nostril. Does anyone know when you wouldn't typically put a nasopharyngeal airway into a nostril as an adjunct in a trauma patient? So yeah, facial nasal trauma, absolutely. A fractured base of skull. So yeah, if we're concerned of a basal skull fracture, you wouldn't typically put a nasopharyngeal airway in. Yeah, well done. In the bottom left, you've got what's called a cricothyroidotomy or surgical airway. And this is kind of a last resort for patients, where patients come in with gross facial edema, airway swelling, sort of tracheal fractures. And in the situation of where patients cannot be intubated or you can't oxygenate the patient, a surgical cricothyroidotomy will be performed by an appropriate senior doctor or senior clinician at the time. And that essentially goes into the cricothyroid membrane just below the thyroid cartilage, as you can see in the bottom left there. When is a retroglottic airway device used? That's a really good question. I'm honestly not entirely sure, but I can get back to you. I will leave it to me at the end and I will look that up for you. So, okay. Breathing and ventilation. So the primary reason that we get adequate ventilation and breathing is to prevent hypoxia of one of the organs and secondary brain hypoxia. So as we said before, we add high flow oxygen to all patients once an airway is established. Even if an airway isn't established before, high flow oxygen in the first instance is an appropriate first step. And you would do a normal look, feel, percuss, auscultate examination in any trauma patient. Really important to assess everything. So the patient's effort of breathing, their respiratory rate, their chest wall movement, their oxygen sats. And it's also important to expose the neck as well, looking at distended neck veins and the position of the trachea. And we'll talk about that in a second, why that's important. Just thought I'd mention a few life-threatening thoracic trauma sort of mechanisms and injuries. So with airway, we're really concerned about airway obstruction. And we've mentioned fractures, upper airway edema, laryngeal injury, and penetrating neck trauma. With breathing, we're concerned if in blunt and penetrating trauma, we're concerned about tension pneumothoraces, open pneumothoraces, and massive pneumothoraces as well. With circulation, we're concerned about bleeding into the retroperitoneal space, the long bones onto the floor depth, etc. Massive hemothoraces and tamponading, and also a traumatic circulatory arrest. I thought this was quite useful, going through the different types of breath signs and the different conditions. So breath signs in a tension pneumothorax can be decreased or absent. With a percussion to the chest in a tension, that's usually hyperresonant, and the tracheal position is usually deviated away. And I'll show you why that is in the next slide. There's usually a bit of backflow of pressure, so that will distend the neck veins. And usually there isn't a lot of movement in the chest. So that's usually the signs that you'll be looking for in a tension pneumothorax. When comparing that to a massive hemothorax, breath signs are decreased and dull. Also, the percussion is dull because you've got a chest full of fluid and blood. The tracheal position is unaffected, and the neck veins are not distended. Usually the chest is mobile in a massive hemothorax. And interestingly, in a cardiac tamponade, although the neck veins are distended in both tension pneumothorax and cardiac tamponade, the breath signs are normal because there's no lung pathology. It's all pericardial pathology and heart pathology. So the percussion is normal and resonant. And the tracheal position is central as well. So just going back to the size, so I've got a question from Daniela. How do you choose this between the tube sizes for intubation? That depends. So I think they go from pediatric size up to 7.5 or 8, if I'm honest. An adult, I believe, will go between sort of 6.5 and 7.5, if I'm not mistaken. I could be wrong. But it just depends on the size of the neck. There are scoring systems that anaesthetists use, but for that's quite an anaesthetic sort of specialty question. So I'm not entirely sure, if I'm honest. Another question: management of major trauma, subcutaneous emphysema, neck and chest, and agitated, desaturated, and hypotensive. Tubes up to 9. Thanks, Diane. Thank you. And Ahmed asking a question: management of major trauma, subcutaneous emphysema in face, neck and chest, agitated, desaturated, and hypotensive. So it would depend what's causing the hypotension, if they've got a tension pneumothorax, for example, if they've lost blood into the chest cavity, and that's why and it also depends if you can get a definitive airway in situ despite the subcutaneous emphysema in the face and the neck and the chest. Is the airway unaffected? So again, it would be starting with A, making sure that there's a definitive airway, initiating high flow oxygen, and then managing C, which we'll get onto in a second. So this is a good diagram of a tension pneumothorax, and I kind of think of it as a one-way valve. So you've got a hole in the internal interstitium of the lung pleura, and that builds up internal pressure and will collapse the lung essentially and cause tracheal deviation away from the tension pneumothorax because of the increased pressure of the air going into the closed circuit. So I think that's quite a useful diagram to recognize. And management of a tension pneumothorax. Does anyone know what the management of a tension pneumothorax is? There's a couple of different options. So needle decompression is certainly one. Definitive management is a chest tube or or a thoracostomy tube. Exactly. So needle decompression versus a thoracostomy. Whenever I was at med school, I was taught that a needle decompression will always go in sort of second intercostal space, mid-clavicular line. But the teaching nowadays is to go in the triangle of safety. And that is demarcated in this picture here. So you've got the posterior edge of the pectoris major anteriorly. You've got the lateral edge of the latissimus dorsi and the fifth intercostal space. So usually you go either mid-axillary or just anteriorly to the mid-axillary line. And when you're going in with a needle or a chest drain, where do you go in relation to the ribs? Does anyone know where you would go in relation to the ribs whenever putting in a block, for example, or administering local anesthetic? Exactly. So the neurovascular bundle sits below the rib. So you would go above the rib below, if that makes sense. So you would always go above the rib because that stays away from the neurovascular bundle. Exactly, yeah. Great, so on to C, circulation hemorrhaging control, hemorrhage control. So on the floor and 4 more, what does that mean? Does anyone know what on the floor and 4 more means? Really useful little, it's a really useful little saying. So basically areas of bleeding, blood on the floor and 4 more. So chest, abdomen, pelvis, and long bones. Exactly. Well done. Sorry, guys. I'm just going to add someone into the. Apologies. I'm just going to admit someone. So these are the areas that we look for because blood likes to go into these areas. So blood likes to go onto the floor. It likes to arrive into the chest, into the abdomen. You lose a lot of blood through the pelvis, and you also lose a lot of blood into the long bones as well. So it's really important to control the bleeding and do that by any means necessary, whilst assessing your organ perfusion, your conscious level, and your sort of central and peripheral power and capillary refill time. And usually to assess and start intervention with circulation, you want to get 2 wide-bore cannula into sort of large vessels in a peripheral access sites, and you can consider an intraosseous needle for difficult access if the patient's really shut down as well. You want to send lots of different bloods, so full blood count, use and ease, LFTs, clotting, coagulation. A VBG will show a lactate. It'll show an acid base level. It'll show a base excess level as well. And depending on sort of the amount of blood, you want to send 2 group and cross match or 2 group and sage as well. So in the sense of hemorrhage control and shock, we're talking about sort of hypovolemic shock secondary to blood loss. One of the questions, would you routinely send a TEG/ROTEM at the same time as the bloods? Yes, in major trauma or major hemorrhage, yes. So a TEG is a way of looking at different aspects of your coagulation, and it will determine the need for things like fibrinogen and clotting factors to stay bleeding in patients with large or major hemorrhages. Can you use IO for adults, or is it just for pediatric cases? You can definitely use intraosseous for adults. In patients with really shut down peripheral veins, you can definitely use an IO. It's typically, in my experience, you get 3 attempts at cannulation, and on the 3rd attempt, if the patient is critically unwell, you just go for IO. How difficult is it to establish an intraosseous line? Not that difficult. I've done it once on a real person, but it's not that difficult. It's like a drill almost. There are a couple of different areas that you can go in, including sort of the tibial plateau or the humeral head, and it just screws in like a nail, to put it quite bluntly. And if the patient needs it, they need it. They will definitely thank you for it later. And it's quite easy you can administer fluid through IO lines, and you can administer lots of medications and blood, I believe, as well, blood products through IO lines. So they're really, really useful. Any special measures for those on warfarin treatment? So depending on the level of bleed, a bedside INR is really important and really useful. So you can assess if they need reversal of their warfarinization. So vitamin K is the antagonist for warfarin. Do you need to provide local anesthesia before establishing an IO line? Yes, it would be nice, but if the patient is critically unwell and they are crashing in front of you and their GCS is dropping, I've seen it being done without any local anesthesia. Okay, great. So classifications of shock. This is also really important. If you guys are in sort of 1st, 2nd year preclinical medicine, it's also really important to kind of get to grips with this. It came up in some of my medical exams. I like to think of it like playing a game of tennis. So 15 to 30, 30 to 40, and 40 above. So those are the scores in the game of tennis, I believe. And it's quite important. So sort of blood loss of less than 15% or 750 mils. You get a bit tachycardic, but everything else seems quite sort of within normal parameters. Patient may or may not be slightly anxious. In stage 2 or classification 2, it can be up to 1500 mils or 30% of your blood loss or blood circulating volume that's lost. And again, tachycardia is the first, one of the first signs, along with tachypnea. And the capillary refill time does decrease very slightly, and the patient becomes a bit more anxious. In level 3 and kind of above, things start to become more noticeable. So the patient becomes much more tachycardic, tachypneic. So respiratory rate is probably one of the most sensitive indicative factors in blood loss. patient may become confused. They may drop their GCS, and their pulse may start to, or the blood pressure may start to drop. And then over 40%, so the 30 to 40%, you're talking about major hemorrhage, and the patient will definitely need blood products to replenish their circulating blood volume, and the kind of method to stop the bleeding as soon as possible. Yeah, we can have the feedback link. Give me 1 second. I'm going to need to just find it at 7. Yeah, sorry guys, I'm just going to have a look for this feedback link. Give me 1 second, please. The talk will be another 10 or 15 minutes, so thank you very much for staying with me. I'm just typing out the feedback link, so just give me 1 second, please. Hopefully that works. So feedback would be really appreciated. So thank you very much. Great. I also thought it would be very useful to just highlight that each hospital will have a major hemorrhage protocol. The principles are the same throughout most sort of all hospital trusts. However, there is minutiae in different hospital trusts. Different types of blood products kind of depend on where you're working. For example, how you activate it is also dependent on where you work. Who you have to discuss certain blood products with, for example, the on-call hematologist, blood bank, etc., etc. So the major hemorrhage protocol is essentially activated when 30% of blood volume, so whenever it goes into category 3, is lost within 3 hours of admission to hospital. And it's usually activated through hospital switchboard or the 4-2s. So usually you would phone the hospital switchboard and say, I would like to activate the major hemorrhage protocol in A&E. Could I please activate that immediately? And ultimately you will get 4 bags of O negative red blood cells with 4 fresh FFP, so fresh frozen plasma. And that will be available to the A&E team or the trauma team within 30 minutes. For that's the amount of time it takes blood to thaw whilst out of the fridge. And then if the patient is continuing to bleed, the blood bank will continue issuing bags of red blood cells, bags of FFP, until somebody stops the major hemorrhage protocol. So if you're working in a hospital or in sort of pre-clinical years, I would definitely familiarize myself with the major hemorrhage protocol. It will be on the trust intranet, undoubtedly. Great. So going on to disability and neurological status. So this is like our A2E assessment. Very similar. So level of consciousness. Although Glasgow Coma Scale, sort of an assessment with formal GCS is extremely beneficial, it is time consuming and it can be quite confusing. I've seen quite sort of senior doctors not disagreeing but discussing, is the patient a V4, are they a V5, are they an M3, are they an M2? AVPU is really quick. So question from SA, what's more preferred and more commonly used, GCS or AVPU? So GCS is the kind of the gold standard, I would say, but a level of consciousness in a patient who's critically unwell, AVPU is so much more quicker. So is the patient alert? Are they awake? Are they conversing? Are they alert to voice? So whenever you speak to them, are they conversing with you? Are they alert to pain? So sort of supraorbital pressure or trapezius squeeze as well, although it's not very nice for the patient. It is part of the assessment. Or are they unresponsive? So it's a 4-step assessment. So glucose level, usually, so Dr. Addy's asked about glucose level. Yes, but with trauma, that comes usually in the E. But yes, BMs as well are a very important thing. But if you're getting a venous blood gas or an arterial blood gas in the first instance, that will have a blood glucose on it as well. Pupillary size and reaction. Sorry, I'm just answering this other question. How does AVPU help in treatment, or is it just used to hand over the patient? So this is part of your assessment, and if your patient is, for example, alert at the beginning of their assessment, and then they suddenly drop to alert to pain, so you have to put a bit of pressure, supraorbital pressure to alert a response. That can be quite sort of an important step in sort of recognizing a deterioration in the patient. So if you weren't concerned about a sort of a head injury initially in a trauma patient, that may put your suspicion of a head injury further up the sort of the worry scale, basically. But yes, it can be used in handover as well. We've discussed the pupillary size and reaction, head injury and neck injury, which we kind of discussed. And essentially, you want to maintain an adequate ventilation and circulation to prevent a secondary hypoxic brain injury. So you want the brain to have as much blood and as much oxygen as possible, so you don't get a hypoxic brain injury down the line, because that would be very bad for the patient. Great. So glucose level, usually in trauma, everything is included in everything else, but in a trauma patient you want to expose everything, so you want to get a top to toe quite detailed assessment of the patient, and you want to further identify any life-threatening or non-life-threatening injuries. So for example, I did a simulation where I had a patient who was in a road traffic collision. They had chest trauma. I managed their chest, but after exposing the patient, they also had scrotal trauma as well. That needs to be addressed. It may not be life-threatening, but it is a source of bleeding. Could be considered pelvic trauma, and it definitely needs to be addressed. So exposing the patient is really important. And patients can get really cold really quickly, especially if they, for example, had a road traffic collision in a rural area. They had a long extrication, they've been exposed by the paramedics, and then we're exposing them again. Resuscitation areas can be quite cool, so avoiding hypothermia is extremely important. You want a normothermic patient, so someone who is within normal temperature limitation or limits. And then again, you want to consider their environment. Where did they come from? Were they on a farm? Were they in the sea? Were they in a reservoir or a pond? Do they have broken glass around them? Did they go through a windshield, for example? All of these confounding factors are really important in your assessment and ultimately treatment, because certain bacteria live in seawater, certain bacteria live in animal feces. So you would want to cover with certain antibiotics, antifungals, etc., etc. But you'd probably get advice on that if you were uncertain. Great. Then other considerations, things that we haven't really discussed. So observations, that's kind of a given. You get that on arrival, essentially, from the paramedics, and then you get repeat observations from your nursing staff or one of the other doctors or clinicians. ECG is also important for cardiac monitoring. ABG, BBG we've discussed. A urine dip if we're concerned about hematuria, penile trauma, urethral trauma, for example, as well. Then we go on to imaging. So you can get bedside chest x-rays. You can get dedicated x-rays if you're concerned about peripheral or long bone fractures. You can get spinal x-rays as well. Usually the A&E doctors are trained in fast scanning, so they do essentially an ultrasound scan of the chest and abdomen, looking at any sites of any lacerations or any sort of free fluid in the abdomen or query bleeding points. And then interventions include things like chest tubes or thoracostomies, which we've already discussed, fracture immobilization, pelvic binders, lots of different interventions. And usually the clinician or the person doing the procedures aspect of the assessment in the trauma team will carry out the interventions if they feel comfortable to do so. And then what's next? So we're coming to the end, guys. Thank you for bearing with me. What's next? So after the primary survey, you want the secondary survey happens. I'm not going to talk about this in too much detail, but once anything life-threatening or I'm just admitting someone, apologies, guys. Anything life-threatening is addressed and the patient is stabilized, a more detailed examination, so a full neurological examination, a facial examination looking for any sort of occult fractures, a hand examination, lots of, a formal GCS would be appropriate in the secondary survey. And these issues need to be addressed, and they can be done in a time-orderly fashion. I think what's really important is if you are assessing something and you do an intervention, you basically reassess. So as soon as you do any intervention, so if somebody's had an LMA put in, for example, or a chest tube put in, for example, then you go all the way back to A and you reassess. And every intervention, that's the teaching. So every intervention that's done, you go back to the top and start again. And that way you don't miss anything. And if anything new happens or comes up, then you can address it as it transpires. And then ultimately, we've discussed this very briefly before, but if the patient is stabilized, for example, in a district general hospital, and they've had a C-spine and it shows a fracture, they may or may not need neurosurgical or spinal input. So does the district general hospital tend to have neurosurgery? Not always. That's usually done in a neurosurgical specialist center or tertiary center. So does the patient need to be transferred to a specialist center? That will need to be discussed as well, and ultimately spearheaded by the team lead or the person who's looking after the patient. Great. Last question. Thank you for bearing with me. There are a few different types of special populations which we've briefly touched on. Can you guys think of any in trauma, bringing it back to trauma? So Yashwan, thank you. So pediatrics, geriatrics, so older patients, elderly patients, obstetrics, absolutely, yeah. Athletes as well, absolutely, yeah. Yeah, I think that's it. I would probably put obese patients in that category as well, morbidly obese patients. Their physiology is slightly different. But essentially, we've covered it all, haven't we? So pediatric patients, that ranges from neonates, so those who are a day old, versus sort of 16, 17-year-olds with the build of a full adult. So with each age group, they have their own unique physiology. They need bespoke levels of fluid, of medications, and typically younger patients, they compensate really well. So they don't get sick until the very last minute. So pediatric patients who come in with trauma are taken really, really seriously. And that's why pediatric trauma call is probably the most medical professionals in one room that you may ever see in a hospital. It is really a sight to behold. So it's definitely worth being at least in the background and observing it if the opportunity ever arises. In geriatric patients, because lower sort of blunt force may cause trauma, or lower penetration force may cause trauma. That's usually considered what we call a silver trauma. So patients come in with falls, come in with head injuries, with collapses, etc. We've discussed obstetrics. So they themselves, pregnant patients have their own unique physiology. They have higher circulating blood volumes. So again, they may compensate a little bit more. And going back to the major hemorrhage protocol, there is usually a major obstetric hemorrhage protocol. And again, that is a protocol directly for obstetric patients, and each trust will have their own guidelines on this. And then going back to Dr. Yari's question earlier regarding a patient, sort of an Olympic or Olympic level athlete, they usually have big heart muscles, they have low blood pressure and a low heart rate. So they have typically lit manifestations of shock. So it's just to be aware of as well. Great. Okay, this is the last slide, I believe. Oh, I don't think the feedback link was sent. Let me just check. Apologies, guys. So I sent it to everyone in the waiting room and not everyone in the meetings. Thank you. So progression of the case all the way back at the start. So the patient is now alert to pain. They're mumbling. We can't really understand them. Their respiratory rate is quite low, and their SATs are really low as well. Their right eye is now dilated and fixed. What are your concerns at the minute? So this is going back to the 24-year-old chap earlier in the high-speed RTC. Does anyone have any concerns? The link is not working. I'm really sorry, guys. Give me 1 second. So have a think about what your concerns are, and I'll write in another form here. Hang on. Oh, apologies, guys. Sorry. Let me try one more time. Try that, please. Yeah, exactly. So the main concern is that this patient may likely have a traumatic brain injury. We noted a right-sided frontal hematoma earlier, and they were initially alert. And I suppose this is going back to why ABFU is really important, because the patient was alert initially, and now the patient is alert to pain. So that quick assessment means that something's going on. The fact that the patient's right eye is now fixed and dilated, that's really a concerning sign, because that's not normal. And that usually happens whenever there's a build-up of pressure in the skull, because the skull essentially is a box. And if you increase the blood, if there's blood in the box of the skull, the pressure goes up. And that will ultimately cause clinical signs such as this. Can I just ask, did that form work, everyone? So this patient needs neurosurgical. Thank you very much, everyone. Thank you. This patient ultimately needs neurosurgical input. They need a CT head, they need a CT scan or a CT trauma series. So if somebody comes in a high-speed RTC, they usually get a trauma series. So that's a CT top to toe. And that may initially not have shown a traumatic brain injury, because these things can develop occultly, especially in young patients. He may need a repeat CT scan and urgent neurosurgical discussion with the CT results. And if the patient is in a district general hospital, for example, where will the patient need to go? Can they deal with it if it's a neurosurgical issue and neurosurgeons want to see him or the patient? Trauma center, major trauma center, exactly. So a major trauma center or a specialist center. Excellent, well done. Good. So this is definitely the last slide. So a bit of a summary. Consider the mechanism. May give you some clues as to what type of injury that we expect. Definitely secure the airway while stabilizing the C-spine. So C-spine immobilization is super important. The whole point of correcting the low SATs, so the low oxygen levels, and replacing the circulatory blood volume, we need to stop the bleeding, and we're going to stop secondary hypoxic brain injury. Important to consider environmental impact on the patient, and after resus, where does the patient receive definitive care? That's a good question to always ask yourself. Can the patient be ultimately managed in the hospital that you're currently seeing them in? Great. Okay. Thank you, everyone, for bearing with me. That's the first time I've managed to run a session and field questions and do the talk. So thank you for bearing with me. Really appreciate it. I don't think this is the right. Hang on. Let me just copy and paste the correct feedback link. No problem at all. Thank you very much. Any questions at all, I'll try my very best to answer them. There was a question about a retroglottic airway, so I'm just going to have a look at that as well. Retroglottic airway. Could be an eye gel. Let me just have a look here. So an eye gel is a supraglottic airway. It sits above the cords. And a retroglottic inflicts retroglottic. So I think a retroglottic airway, according to this, is essentially just a normal intubation tube. It passes beyond the larynx to enter the upper esophagus. So it's used as an alternative to endotracheal intubation for advanced airway management. It's placed in the esophagus and serves as a mechanical airway when ventilation is needed for patients over 4 feet tall. Yeah. To be honest, Sahil, I have not seen that being used in practice. Does anyone else have any? How can a prospective FY1 A&E prepare for a major trauma case? So you're, as an F1, you're going to have an educational supervisor and a clinical supervisor. You'll definitely have a clinical supervisor in your A&E placement. make yourself known to them quite early on, and say, I've got a real interest in observing major trauma or resus cases, and I want to get involved as much as possible. And they should help you facilitate that in a way that is safe and sort of beneficial for you. And if you've got some smart goals, so if you've got, I don't know, I want to assist in a major trauma case over a 4-month period, I will be assessed by my clinical supervisor and gain feedback from the team members around me. That's a goal, for example. That's very achievable in a 4-month placement. But I think, you know, you're going to be under the supervision of a senior clinician, so they can definitely help you with that. We have information on bullet types, etc., for a view of possible damages. I don't, unfortunately, but if you do, that I'd be really interested in seeing a resource for that. I do remember him. I think I was maybe first or second year medical student, and there was a slide showing the different soft tissue injuries comparatively with different types of bullets. Different bullets spiral in different ways, or different bullets are made in certain ways to injure patients in a specific way, but I don't have that resource, unfortunately. Any other questions at all? Final link for the feedback. Be very grateful if you could give us any feedback. Oh, that's directly to Yara. I'm going to stay on for another couple of minutes. Guys, if you've got any questions at all, or anything you'd like us to cover in future from the Medicine as the Essentials point of view, please let me know, and we will try and organise another talk. We can organise part 2 of this and go into a bit more detail, if you like, in terms of trauma management. Look at the special populations, if you like, different, and organise a few different cases as well, if that's something you'd be interested in. Thanks, Madhu. Thank you. It's just Logan, by the way. Just call me Logan. Cool. Another minute, and I will disappear. All right. All right, everyone. Thank you very much. See you later. Bye.